Today's webinar is titled The Winning Edge for Clinical AI Implementation, and this is sponsored by Microsoft. Thank you to our sponsor for making today's program possible, and to those of you in the audience who are participating. Before we get started, I'm going to I have a few housekeeping details to get going. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel on Friday, and it can be accessed using our website, healthleadersmedia.com. Now, to ensure that you can see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and or PC speakers for optimal sound quality. Again, we are having issues, so please bear with us. You'll find a resources list as well for today's webinar on the upper right of your screen. Here we've listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events. And at the bottom of your console are multiple widgets for you to use. Again, you can submit a question. We're hoping that we can get Q&A back before the end of this session. If not, the questions that you asked will be passed on to our presenters who may be able to answer them at a later date. If you want to submit a question to the Q&A in hopes that we will be able to answer it here, click on that Q&A widget. It can be open already and appear on the left side of your screen. Good luck. And aside from that, you'll also know that if you're experiencing any technical difficulties, and who isn't these days, there is a help widget there. It may work, it may not. It's kind of a crapshoot right now. Hopefully, you can see us, which is the most important part of this event. And I'm going to go right on and get into it now. At this time, it's my pleasure to introduce our panelists, and we've all had quite an adventure to get to this point today. Yaron Elad, Chief Medical Informatics Officer for Cedars-Sinai out in LA. Yaron is actually going to be doing the slide deck for me because he's the only one of us who can see it right now. Sarah Vaisi of Providence, she's the Chief Transformation Officer there up in the Pacific Northwest. It's a pleasure to have both of you in this conversation today. We also have Dr. Jared Pello, Chief Medical Information Officer for the Health and Life Sciences Unit of Microsoft, who is also joining us for this conversation. Now, what I want to do is just jump right into the actual conversation. The first question I'm going to have is one that I can't see, but I'm going to start with Sarah on this. Could you please tell us a little about yourself in Providence and how you're deploying AI in clinical care right now?
Absolutely. Eric, thank you for having me. And hopefully our technical difficulties somehow magically disappeared today. It's great to be here. I serve as the Chief Transformation Officer at Providence, which is a large integrated delivery network up and down the Western United States. We operate in 7 states, Washington, Oregon, California, Texas, New Mexico, Montana, and Alaska. And we serve 5 million folks across our communities every year. We have 52 hospitals that we operate, over 1,000 clinics, and we're really fortunate to have about 15,000 physicians that we work with, 45,000 nurses, and overall about 120,000 caregivers. We call all of the folks that work with Providence work and serve at Providence caregivers. And the way that we're using AI in the clinical setting, I mean, we've been using AI for many years. And so, these days we talk about AI as though it's like a new thing that folks have just discovered since November of 2022. And that's not the case. We've been doing work around predictive AI or detection, or supporting a lot of both administrative and clinical functions for probably over a decade. But because we've had such a major sort of sea change in technology with GPT and large language model powered technologies becoming more broadly available since November of 2022, we've really supercharged our efforts. And where we focus primarily, and I'll talk a little bit more about it, is I would say in a couple categories, all focused on improving clinician experience for the most part. And the areas where we focus are, I would almost call it like operational AI for a clinical user. So things like supporting our physicians with ambient assistance, so they have to spend less time charting and documenting. We also have sort of this end-to-end, a novel approach to reducing in-basket messages, which is essentially the clinician's, kind of like email inbox, if you will, to put it very simply. So those are the areas we've really, doubled down on clinician experience, and some of the areas where patient experience actually influences clinician experience, and we can talk a little bit more about that.
Thank you. Okay, Yaron.
Morning. Happy to be here. Happy to be running the slides. All of us in health informatics end up being the high school tech guy at one point. So it's good to relive those days. I'm Yaron Elad. I'm the Chief Medical Informatics Officer at Cedars-Sinai Healthcare System here in Southern California. Much smaller than Providence. We have 3 affiliated hospitals and take care of the population all over Southern California. I'm still a practicing cardiologist as well, so I do see patients in my spare time. Kind of along the lines of what Sarah was saying, definitely been an explosion in AI, and my email in basket has been exploding with vendors, offering their wares to us pretty much all over the all over the healthcare system at every level. We're an Epic shop. We use Epic as our EHR here, so a lot of the AI that we're using is driven by what Epic makes available to us. Though on top of that, we also work with other vendors in other capacities. Similar to what Sarah was saying, ChatGPT coming out was certainly a turning point, and definitely leveraging language models throughout the medical center for various use cases. Similarly, also, we've really focused on our clinician experience. Ambient AI, we've had a pilot. We've actually moved into implementation now, but we've been testing ambient AI for almost a year and a half. And other things like augmented response technology, which is the in-basket product that helps tee up responses to patient messaging, and certainly also moving heavily into chart summarization tools now as well, both for our clinicians, but also for case management, for nursing, all across the medical center. That really seems to be the use case that we're going to focus on, I think, moving forward as we get going with the other AI augmented products. But lots and lots of requests for things like chart summarization. Definitely where we're headed.
Nice. Okay, and Jared.
Thanks, Eric. It's great to be here with Sarah and Yaron. I'm Dr. Jared Pello. I'm an emergency medicine physician by training. I'm at Microsoft, one of their chief medical information officers. There's 4 or 5 of us within the health and life sciences division. My path here began a little over a decade ago as an ER physician trying to solve my own problem. I created a small virtual scribing company. At the time, it was called iScribes. We ran it for 3 years, and we were acquired by Nuance Communications, and we built Dragon Ambient Experience inside of Nuance. And then, of course, the partnership between Nuance Communication and Microsoft led to the acquisition of Nuance Communications by Microsoft, and we've now created Dragon Copilot, which is our newest iteration, and really much more than an iteration on things we've built before. It's really a transformational move to bring kind of Copilot technology to the fingertips of our providers that we work with, and their ability to do all sorts of new things, including building their own extensions, their own Copilots, and bringing that into their own workflow. And so this has been a really exciting time for me. As Sarah mentioned, working on AI before AI was as cool as it is today. And I think the big moment was when everybody got to interact with an AI and it interacted back with them. And that kind of changed everybody's mindset on the possibilities of what could happen. I remember when we first built our first large, well, it was probably small language model at the time, with all the data we had collected for the first 5 years of collecting doctor-patient conversations, the output was terrible. But it started giving us a signal of where we were going. And it's remarkable to see how far we've come. I remember pitching investors back in the day, and they would ask me, and it was actually about 6 years ago today that I was pitching an investor, and they said, "How soon until this is fully automated?" And I said, probably 6 years. And honestly, just a lucky guess at the time. At the time, that investor said, "That's way too long. I'm not going to invest." But it's amazing to come to this point where we see so many great technologies kind of coming to bear. I'm really excited to hear and participate in this conversation with you all.
That's great. Thank you very much. Now, as I said, we have questions, and this is going to be the basis for this conversation. I'm going to launch into the questions I have, and because I can't see the questions, I'm reading off my original script here. And my original script had called for me to ask about how you're deploying ambient AI. Now, we've already kind of started down that road, so I'm going to jump from one to the second one on my paper, which basically, instead of telling me along with telling me how you're deploying ambient AI, could you tell me a little bit about how you're measuring, or how you will measure, this program for success? What are the metrics you're using to prove that this particular ambient AI tool is working for you? Yaron, I'll start with you because you're just getting now into deploying it across your health system.
So we've been using pilots. I mean, we start with small groups. We have a clinical informatics team of physicians actually that I help lead. And generally, we have our physician informaticists try things first for a brief period of time, just to get some understanding of what the technology is and how it works. And then we kind of have our most valuable testers, or we also call some of them our most valuable complainers, because we utilize them specifically to help us kind of flesh out, new technology, and they're willing to do it. So whether it was the augmented response technology, or specifically ambient AI, we selected a couple of vendors after hearing from many vendors, actually, and continuing to hear from vendors. There's really a lot of vendors in the ambient AI space. How that all panned out. But selected 2 vendors and kind of did a head-to-head pilot over a few months with 50 clinicians here, and kind of had both of them available to the 50 clinicians, and encouraged them to use the vendors as they liked. Kind of paid attention to who was using what, and sometimes would have to give them a small nudge, maybe try the other one. And we did that for a period of time, and collected data, both extensively using Epic Signal, which provides us with a lot of very useful information. And then we also created our own questionnaire that we circulated amongst our pilot users and asked for their feedback to see how they kind of were responding, and what they liked, what they didn't like. The other thing that we did, which I think was really successful, and maybe created a little bit of a buzz and an excitement, was we created a Teams chat just for our pilot members, and we kind of encouraged them to interact on that Teams chat and give each other pointers, ask questions, certainly report technical problems. So our technical teams were also monitoring that chat, and turned out that really kind of created a community of ambient AI users very early on, who really were the ones who were engaged, were really excited about it, and that was one of the ways their excitement. So that's kind of how we started, and then kind of I can get into what our findings were in terms of the KPIs, in terms of the performance metrics that we looked at, but maybe we can come back to that. I'll let Sarah share how they kind of started.
Certainly. Go ahead, Sarah.
Absolutely. Very similar methodology. So we used, we were really looking at how, like, I would put it in a couple of categories. Performance as it relates to reducing the amount of time that folks have to spend in notes, in, in the, whether it was like in clinical review per appointment or time in the notes per appointment. We looked at pajama time. We looked at efficiency scores. We looked at appointments per day, though we didn't tie deployment of ambient in any way to productivity requirements or measures. And then we also looked at provider and clinician satisfaction. We asked folks, like, would they be disappointed if they couldn't use it? How easy did they think it was to use? Would they recommend it? Are there actual impacts on, like, their likelihood to stay with the organization or practicing medicine, or do they think that it improves documentation quality? So quantitative data from Signal and qualitative clinician satisfaction data that we collected directly from folks. That was all on the ambient side, and we've seen great results so far. And even if the measurable sort of quantitative aspects of time per appointment, time spent, for instance, in notes per appointment, it doesn't universally improve that experience for every single clinician. But what we have heard consistently is it just makes it less bad, like the whole experience less bad. Like, I feel better doing my work. And so that's been really positive. On the in-basket side, we actually have taken kind of two different approaches, and we did not utilize the approach of going with an auto drafting. We actually tested it out, and the models weren't working as well as our physicians really expected them to. And so we stopped doing the pilots that we kind of cut bait after we tested it and it didn't work for our clinicians. But we handled it in sort of the proximal way, which is actually helping our clinicians more easily respond to messages, both understand them more readily as well as respond to them more readily and more easily. And then also kind of reduce the volume on the patient side, because some of these in-basket messages are a function of just patients aren't able to get what they need to get done, and so they send a message, right? So we handled them both. And for those, we looked at time spent answering messages per appointment, time spent, and the number of messages that we're able to, what we call deflect, like just avoid. So we're actually going against like 3 levers on the in-basket side. It's total volume, efficiency of answering messages, and triaging, and like how much we're doing. Those are the 3 levers we're trying to pull. And so we've learned a lot throughout the measurement process on all of those.
Are there metrics that you will use to measure the patient experience? Do you survey the patients to see what they think of these tools?
The short answer is yes. And one is they got to know that they are actually using AI. So you have to be very straightforward and very upfront with it. We blast it all over the place. Anytime we're having a patient-facing AI, we show them in multiple places too, because it's not enough for it to be written in one corner. Like, you got to be very clear. We show it in multiple places. And then we actually, we actually instrument our products so that we can measure how they're interacting, right? Like, how did the model actually, for instance, detect what the patient was trying to get done accurately? That's number one. Number 2 is, were they then able to fulfill what the patient was asking for? And we measure that. So we know that we can get up to like 90 to sometimes 100%, depending on the types of questions, intent recognition. And then we can do like 60% fulfillment based on, and so we measure all those things. We also look at, we also do a lot of user testing and measurement of just whether the patient had a good experience or not too. So we do all of that. And ultimately, again, these 2 problems are very intertwined. So it's not one or the other. If you're giving your patients a bad experience, or for instance, like they're not getting their needs met, it's going to come back and make the clinician experience less good too, because someone will have to deal with that.
Yes. Yeah. And eventually, and I know this is very early in the stages, clinical outcomes are going to be measured eventually. I know it's going to be down the road, but you're setting the stage for that, for an understanding of how these tools actually can improve health. Yaron, same question. What are the KPIs you're using, and are you measuring patient engagement? Yaron, are you there?
Your volume went out.
How about now? Can you hear me?
Yes.
There we go.
Another fun. Anyway, so we're just starting to measure, with real numbers, our patient experience. Subjectively, that was one of the things that we actually asked our clinicians. We haven't surveyed our patients directly about it yet. One of the challenges actually is that, and I'm speaking actually about ambient right now, but one of the challenges is, when the clinicians don't always use ambient on every visit, it gets a little tricky to figure out which metric to measure depending on the clinician and whether or not they used ambient for that particular visit. All of our clinicians are instructed to let the patient know right up front at the beginning of the visit that they're going to be using ambient. And kind of the approach that we've taken is the script, if you will, it's not a written script, but what in our training is to say, I'm going to be using this tool that leverages AI to help me have to type less and be able to focus on you more. And that kind of framing for patients makes them very happy. The ones that we ask immediately will say, my doctor is actually looking me in the eye for the first time in about 5 years. And that's kind of been the subjective response that we've gotten. In terms of numerical things, yes, we certainly are, like Sarah said, we're looking at things like pajama time in notes, et cetera. And we definitely see kind of the modest improvements that everybody's been seeing. I think the realistic number is probably 10 to 20% reduction in time in notes and et cetera. Some of the vendors will quote higher percentages. We haven't seen that. We've seen between 10 and 20%. But I think the remarkable thing is kind of the more subjective response that we get from our clinicians. Along the lines of, I feel like I'm wearing shoes that fit me better when I'm doing stuff, and just I'm not walking uphill as much. It feels like I'm walking downhill, and really, folks saying that they get to go home earlier and the pajama time piece, whether or not it's a 15 or 20% reduction, the perception for sure is that it's a lot easier. I'm a user as well. I use the ambient when I see patients. Occasionally I forget to turn it on, and then I come back to my desk and I'm like, oh no, now I have to type. And it's actually an insult to have to type, especially when we have this technology available to us. So all the markers are really great. You kind of touched a little bit on clinical outcomes. The other piece, of course, is ROI. What's the return on investment with this technology? Because there are costs associated with it. Right now, we're focusing on our wellness ROI, which is certainly very important to us. But we also hope to see other forms of ROI, and we think as the technologies mature and things like coding come online, improved coding and things like that we'll be able to leverage some additional ROI beyond wellness.
Great. Okay, thank you. Now, Jared, I want to bring you in on at this point too. Can you tell us, is this kind of the industry standard for health systems that are deploying ambient AI now, or are there other KPIs out there that health systems are using to prove the value of this tool?
Yeah, I mean, not surprising that we are kind of hearing the industry standards from Sarah and your own. I mean, two of the leading health systems in the US speaking to us. But what's interesting is over the last year, we have started to have peer-reviewed papers on this as well. And so, Stanford, Atrium, University of Pennsylvania, Kaiser, most recently, all publishing data around this. And what's interesting when you look at those papers is you can pick out trends, and there are different time horizons for each of those papers. And what I've seen over following where we've implemented for years is that the benefit grows the longer somebody is on it and the more they use it. And so I'll just call out, like, one of the papers in their sub-analysis, they said that their highest users saw the biggest benefits. And I think that's true. I mean, with many tools, right? The more you use a tool, the better you are at a tool, the more efficient you are. And then what I've also seen is typically, and I'll tell health systems this, it's going to take 6 months just for the doctor to feel like a human being again, just to feel like their feet aren't to the fire all the time, that they're on the hamster wheel. But after that 6-month mark, you'll kind of, and best use case also, we tell health systems, it's probably not to give the tool and say, and we expect more from you. It's really like, here's a great tool to help you feel like a human again. And usually after 6 months, and if not 6 months, a year, you will have physicians saying, hey, I feel like I can see more patients. I'd love for you to add more to my census, because, access to care is so big right now. We have such a shortage kind of everywhere. And so getting patients in a timely manner, especially to specialists and subspecialists, is such a big push. And so, yeah, I think the KPIs that were talked about, of course, pajama time, burnout, perceived burnout, burden of documentation, all of those things are huge. The other thing I will call out is we recently did this partnership with Press Ganey so that we can start giving insights back to health systems around ambient and be able to kind of survey the patients who had ambient done for them. And so that's going to be an exciting partnership to be able to prove out the kind of ROI there as well.
Yeah, certainly. Okay, I'm going to move on to the next question now, and I want to point out that I can move on to the next question now. We are slowly getting functionality back on this site, and I want to take a step back a little bit. We talked about deploying and getting it into doctors' hands and all that. Let's talk a little bit about the process, or what it took to get doctors to introduce them to this tool. One of the biggest, probably the biggest issue with any tech implementation is change management. We know healthcare is a traditionally conservative industry. People don't like to change too much. They don't like new things. So how difficult was it to put this tool into doctors' hands, and what did it take to get them comfortable enough to use it? I'm going to start with you, Yaron, on this one.
So we've taken a cautious approach in terms of our rollout. I know there are institutions that kind of make a decision. We're going to go with ambient, and we're going to offer it to everybody, to every doctor in our healthcare system. Thousands of clinicians taking it on at once. We've kind of opted to go slow. And put out, initially we had our pilot where we kind of hand selected our testers, and then as we've rolled it out more widely, we've solicited from our medical network and from our faculty, and also from some of our private physicians. We've sent out a message saying this is available now. If you're interested, please let us know. The interest right now is more than the number of licenses that we've made available. We are planning on adding more licenses as necessary. But we actually have a waiting list for certain clinics to add on more users. And again, that's kind of a self-inflicted scarcity that we've done just to kind of get started and make sure that everything works the way that we want it to work, and we can keep an eye on it. What we've found, and I think the experience that I've heard, at least from other CMIOs, et cetera, is that if you roll out to the entire kind of healthcare system, you end up with maybe about half of the clinicians being serious users, maybe more, maybe some less at other institutions. What we found is that when we roll it out to people who really want it, they really will use it, and they really give it a good try. And that's a really important piece is that we learn is that if you give it to people and they try it once or twice and give up, they usually might say, it's not worth it. I don't want to learn, I have really great smart phrases and I don't need to learn something new. So we really encourage folks to really give it a real try. And for some of our clinicians, I've kind of used the analogy of a parent offering their child a food that they know their child is really going to love, but the child refuses to try it. So I've used that analogy successfully, and we've had folks who sometimes kicking and screaming, and we know our clinicians, right? I've been here for 20 years. So we know who's going to benefit and who's going to like it. And then the other piece is also to be very accepting of the possibility that not everybody is going to like it or want to use it. Folks who are really, really great at using Epic may find that it's not for them, and that's okay. On the other hand, there are others who really, really end up loving it. The out of my cold dying hands analogy fits with some of our clinicians who literally by now have used ambient AI for thousands of encounters and couldn't imagine practicing without it. I'm reminded of one of our clinicians who's been around for a while. She's near retirement, and she sent us a message that she'd been on vacation for 2 weeks, and when she came back and she was so excited to get back to her ambient scribe with 2 heart emojis on the message. So it's stuff like that that has been really, really wonderful actually to see. But I think kind of that flexible rollout has worked really well for us, and giving it to people who want it at this point. And the buzz is definitely increasing. So-and-so, I heard from so-and-so that they have it. How do I get this? What do I need to do? And that's kind of been very effective. And our plan is to ramp it up as our clinicians demand it.
Okay. Now, how about you, Sarah? Was change management an issue with this? Did you have to struggle to get physicians to buy into it?
Change management is always an issue with anything new and different. But I think what your own referenced a couple times is physicians are not, or clinicians in general are not a monolith. You have in many other, just like you have in other domains, you've got early adopters and folks who are really raring to go and try something new. And then you've got folks that are fast followers. And then you've got the bulk of folks, and you've got folks that are I never want to do this. Please don't make me. And so building an approach that that is flexible and recognizes that they're not a monolith and that different folks need different things has been what we've done. And one of the ways that we've done that is, we started out early with certain folks who really were raising their hands and saying, we want to participate, we want to experiment, we want to be at the forefront of utilizing these new tools. Some of them are we have a lot of fantastic young clinicians who might also have computer science backgrounds or might have, product backgrounds, and they are really interested in these types of things. And so we started that way. We're now at a point in our journey where between our clinical network and our CMIO and his team, they have built a cohesive plan to kind of go and roll this out more generally across the organization, but recognizing that each of the, again, we have different levels of readiness throughout the organization. And so we've gone kind of deep into our organization to partner with the medical groups to say, please raise your hands for folks who are ready within your medical group. Get sort of that organic groundswell. Combined with you might call it traditionally more top down. We do now have organization-wide goals for rolling out ambient assistance and in-basket management throughout our organization to ensure that we can start to get the benefits. If you don't use the tools, you're not going to get the benefits, right? Very simply put. I think Jared may have mentioned that, and so that's what we're trying to do. And we're past the initial point of just trying to get that initial wave off and running. So it has to be owned by our clinicians themselves, and that's how we've done it. Our clinical network and our CMIO and their teams are working at it. So that's where we're at.
It looks like Eric froze.
Froze.
So Jared, what's
See
your
if we can work things out.
out?
Do I have anybody with me? I seem to see everybody frozen.
There you go.
Oh,
now we see it.
No, he's back. He's back.
Okay, we're all back. I want to point out we are past the halfway mark here, and we do have Q&A capabilities back too as well. So, so certainly send in your questions if you want. Jared, I wanted to give you an opportunity to answer this question as well. Is what do you think? Is this typical for change management? Any other tips
I loved the food analogy from your own. I have 4 kids, and I've gone through this with all of them where, they never were going to eat sushi, and now if I take them to sushi, they eat way too much and it's way too expensive. But yeah, I think it's so interesting. You also see the change management from the leadership style of the CMIOs. And what a wonderful time we're at, where we have chief transformation officers and CMIOs, where 10 years ago, you were lucky if you had a physician informaticist. And now we have teams of physician informaticists. And I think that is also just such a wonderful thing as this technology is hitting, because there is so much change management. And I think it is so apparent right now, the return on investment for having great informaticists within organizations. And what I think is neat is you've seen over the last decade or so, as informaticists dig in on Epic, the ability to drive an ROI for their health system. I think we'll continue to see that with ambient and with these new technologies, is that informaticists are going to be the ones locally driving that ROI, maybe even on top of, or even more than what the vendor themselves can drive. But I think that leadership from the transformation officers, from the CMIOs, is really key for that change management. Because if you really have a champion and you have a champion team leading that change, it makes all the difference in the world. If I have a administrator telling me how great a product is, or if I have a peer telling me how great a product is, a peer who has continued to make my life better over the last 5 years with the tools I use, I'm going to trust it so much more coming from the peer. So I think that's huge for change management as well, is making sure it's clinician led and really driven from kind of that grassroots. And then eventually you get to that point, like Sarah talked about, where it's more this top down, like we really want people to adopt these tools because we see the benefit that it's driving for everybody.
Yeah, definitely. We got a lot of ground to cover here, and we're running out of time. So I'm going to jump right to the next question. I understand this conversation we could have all day long. So I know we're not going to get all the questions or all the topics here that we want to talk to. I did want to go into a little bit about some of the challenges, or if any, that you're seeing in this. And I posed it as, what has surprised you about this technology? Are there any common assumptions that you warn other health systems to avoid when you're talking about ambient AI? Sarah, I want to start with you on this one.
I think we're still, it's sort of it's a little bit of the self-driving car analogy that folks often use. Self-driving cars, and there's a lot of studies out there that say like self-driving cars actually have higher rates of fatal accidents or other issues like that, but they are loaded with safety features. They have lots and lots of technology capabilities that make them ostensibly safer. The challenge is the conditions of the driving conditions combined with the driver's situation in a given moment can make it more dangerous. And I think we have to also be aware of those same types of things playing out when it comes to whether it's ambient assistance or in basket. And it's a little bit, it's not widely applicable, right? If you're in an unsupervised use case where there isn't like actively in real time a human in the loop, that's a different kind of scenario. And we have some of those as well. But when it's supervised, like, do you really want a clinician having to go through and just be like, yep, looks good, yep, looks good? Probably not. I mean, there's a higher and better use of a clinician's time than that even, right? And so I think how we work with the tools is going to be, it's still mature, like our concept as an industry is still maturing. And there's still lots for us to learn and uncover and new use cases and things like that. When it comes to the technology just purely itself, sometimes these non-deterministic things do have a mind of their own, and you can put all the guardrails you want, you can put constraints, and they do things that are a little bit like unusual. I mean, especially in unsupervised use cases. And so we've seen that happen, and we have a very sophisticated set of monitoring and both like pre-deployment like sort of testing and validation and real-time monitoring and auditing processes, and still interesting stuff happens that we were not expecting. And so I think the short answer is we all feel like we've done a lot and we're just at the very, very, very baby stages, and there is a ton to uncover. And now is not the time to like take our hands off the wheel in terms of, and I don't think anyone would ever say that, no, certainly not Yaron and Jared, but we have to be very vigilant because like it's easy to build for the 80% or to address the 80%, but there's very, very long tails and lots of edge cases, and that's where problems can arise. And so like models doing things that you didn't expect them to do, even with the constraints, or just like not great performance perhaps. And so people, like, you don't get user acceptance, and physicians might say, hey, like, this sucked, I didn't like it, I don't want to do it anymore. And then that could put you back from a change management perspective, right? There's all of these things. And so it's really critical to go deep, pay really close attention to all the use cases, all the edge cases, and uncover this stuff as we go along.
Nice. Yeah. Yaron, same question. What has surprised you about it so far, and how are you handling governance?
Yeah. So what's kind of interesting about these AI tools is that as informatics officers, we tend to like to roll out kind of finished products or as close to a finished product as possible. I think this is one of the interesting cases where you have a technology that's really, really rapidly developing, really rapidly iterating, and the ambient scribes that we're using today are different than the ones, even though it's the same vendor, same company, everything is much different than it was 6 months ago. And that's kind of unique. It's been kind of something that we've shared with the clinicians in our pilot. We're kind of aware that it wasn't quite that we were beta testing, but it wasn't really, it was a product that's still approaching maturity. And I think that we're actually kind of far from these products really being mature. But it was kind of an interesting experience to roll out a product that is so rapidly iterating and so rapidly evolving, and with all the pitfalls that are associated with that. The good news is that for the most part, the products are pretty good about not hallucinating, not kind of doing things that we wouldn't expect them to do. I think kudos to the vendors for paying close attention to that as well. And then when our clinicians do notice something, we do let the vendor know, and they try to understand why it happened, et cetera. And like I said, our certainly our pilot clinicians were very kind of accepting of the fact that this was new technology. From the perspective of governance, I think there's kind of where we're going to be, I think, for the next couple of years and where we hope to end up. I think for the next couple of years, we've added a layer of governance to all of our AI tools that we're bringing in. We have a kind of an overall kind of AI council, and then we have sub-councils for physicians and for clinician, for nursing, for operations, et cetera, all kind of working together to evaluate the tools that we have and the tools that are being considered to be implemented. In the long run, I hope that we can kind of lump our AI tools together with any new technology that we bring in, and won't have to go have this extra layer of vigilance that we have for now. I think it remains to be seen if we can achieve that someday. But hopefully the tools will get so good and be so reliable that we won't need to kind of go that extra step. But for now, we're very suspicious. So we definitely keep an eye, and everybody's kind of on the same team with this. I think both the end users and the vendors really want this to work right and to work well. So that's kind of where we're at with that.
Okay, great. Now, Jared, I'm going to phrase a question a little bit differently, and it lays the groundwork for a couple of the questions we're getting into the Q&A box, and then I will ask Aaron and Sarah the same question. You know, how do you see this technology evolving? In particular, nursing. How, you know, where will this technology go that we can help nurses with their workloads?
Well, I think we're finally at a very exciting point for nurses, especially in the Epic space. You know, it's been a lot of work with Epic over the last 6 years, really, to get ready for the physician space and now the nursing space. And, you know, so much of the nursing work is flow sheets and needing to click boxes or enter discrete data into a field. And we have hundreds of nurses live now using Dragon Copilot Nursing, which is really exciting in our private preview. And that will become generally available later this year. And so I think that's going to be huge. That's for inpatient nurses. We also have some early tests with nurses in the ER using more of the ambient listening type of capabilities for kind of triage and note writing. And so I think, and kind of like Sarah said, these caregivers, no matter whether they're physicians or nurses or medical assistants, anybody who needs to do documentation in the electronic health record, you know, physical therapists, respiratory therapists, whoever it is, like they all have this burden that we can solve with ambient AI technology. And the good thing is, this is good for everybody. It decreases the burden. It should decrease cost for everybody. It should, you know, kind of the ubiquitousness of this technology as it comes about. And our chief strategy officer, Peter Durlock, will often call it's the exhaust of the conversation. Like, you're having this conversation anyways. Why not take the exhaust and make it useful? And so I like that thought of like a nurse talking with the patient and having their flow sheet filled out for them. So I think it's a really exciting time for that.
Now I'm going to turn this question back to Sarah. What would you like to see AI used for in the future? And nursing can be one element of it, but where else do you see this type of technology really helping you out?
I think in the near term, and we spend a lot of time with the Microsoft Nuance teams on this work, is expansion of settings. So not just clinic, but also inpatient ED. We've actually started piloting in our EDs, and folks, you know, anecdotally love it. It's really helping them a lot. But it's expansion of setting, it's expansion of the user base. So it's not just physicians, it's nursing, it's other APPs, it's MAs, it's techs and other things like that. So we see like expansion ubiquity from a setting and user perspective. But then you actually think about the depth associated with what it can do, what the solutions can do themselves. So we talk about like, why would a human being, especially a highly trained clinician, ever have to do anything involved with coding, right? So then you start getting into the clinical documentation improvement, and the whole CDI space, I think, is going to get completely disrupted. And then there's, and so those are all like taking out administrative burden and that kind of thing. But then why don't we start adding back useful stuff? That's one of the benefits of AI, is actually augmenting with new information that actually makes the work better, improves the outcomes, improves the experience. And so like starting to get into clinical decision support, I think it's going to be something that we're going to see in not that long, probably within the next 24 to 36 months. So those are the types of things I get really excited about. And I think if we, like, our aspiration looking forward is truly marrying humans plus machines from an augmentation standpoint when it comes to clinical activity, really supporting our clinicians with new information, with tools, so that they can focus on the same stuff that is the higher order stuff that they really like to and are trained to do, and then everything else we move off their plate, and so some of it will get automated, but then really it's that augmentation thesis that we're working toward.
Nice. Okay, Yaron, same question. Where do you see this going in the future? What would you like to see it used for?
So it's always terrible to be the last guy to go after everybody has spoken because they say all the good stuff. But just to kind of reiterate a couple of points, one of them is, inpatient and ED for physicians is definitely, there's a void that hasn't been filled yet really by any vendor. In a good way. I mean, they're making efforts and that's great, but I think that's the next frontier on the physician point. Certainly nursing, I think I like the exhaust analogy. I think, just having the conversation, you can fill out the flow sheet with the conversation. Absolutely. But what Sarah said about clinical decision support to me is actually the most exciting piece. Going beyond things like coding, the other thing to mention, of course, is I think ambient opens up lots of opportunities to kind of leverage the conversation that occurred between the clinician and the patient, whether it's teeing up orders, which I think is low hanging fruit that I think the vendors are already working on and coming up. But what I'd really like to see is almost real-time clinical decision support. So the example is I'm seeing a patient and they tell me that they have a family history of hypertrophic cardiomyopathy. So I order an echocardiogram and I order some electrolytes, but maybe I forgot to order genetic testing, and maybe the ambient AI, as I'm reviewing my orders that it has teed up for me, might be a little box that says, hey, do you want to order genetic testing for hypertrophic cardiomyopathy? That would be really useful. And it doesn't take control away from the clinician. Like Sarah said, it really augments our ability to take the best care of our patients that we can. And that's where I'd like to see things headed.
Yeah, the potential is certainly amazing. And Sarah, I liked what you said. I mean, we've talked so much about AI reducing the workflows or reducing the workload, improving the workload by making things taking away. And eventually we're going to be talking about AI adding, or as you say, augmenting the workload, making it, giving clinicians the tools they need for better care. We are down to about less than 5 minutes left. And I got a great question here that I'm going to kind of conclude this panel with. And it's kind of speculative, but I've been hearing a lot about this. I heard it at CES, at Vive, at Health, at HIMSS this year. The idea that AI is becoming so ingrained. How long will it be before you list AI as a requirement? When doctors and nurses and so on look for health systems that have AI as a requirement for where they want to work. Liability. How long before you can be held liable if you're not using AI? Could you, Yaron, I'm going to start with you on this one. How long is it going to be before this becomes a real standard?
So I think you hit on this earlier, and I think we need clinical outcomes. I think that's really key before we can make grandiose statements like that. I think one of my favorite quotes about AI is that AI is not going to replace physicians, but physicians who use AI are going to replace physicians who don't use AI. And I think that's very true. I also like the formulation of augmented intelligence rather than artificial intelligence for all of the same reasons. I think, it's just organically happening everywhere in life that AI is coming into our lives, whether it's in healthcare, whether it's self-driving cars, or kind of any realm of what we do as the technology advances. It's just going to become part of life in a sense. And the key, of course, is that we use it responsibly and with the appropriate safeguards. So, the question, I think, it's a great question. I think we're all headed that way. I think it's not going to be possible to function in this society without using AI pretty soon.
Okay, Sarah?
I agree. Just in the interest of time, I agree. I think for other like supporting functions within healthcare, though, we are going to see it's going to be an expectation, and we're already seeing it. Like there's a tremendous amount of I have responsibility in the system for all of our consumer-facing front end, so brand, marketing, consumer digital, all that. Like marketing is being massively disrupted. Contact centers are being massively disrupted by AI, and it's going to become a necessity. I think the clinical complexity is going to make it such that we really do need clinical outcomes, as Yaron pointed out, before we start to say, oh, it's an absolute requirement. But for other things, I don't think it's that far off. I think within 2 years, we're going to see a lot of automation in those spaces and a requirement to have lots of tools available, and because there's a huge cost imperative.
Now, do either of you list, when you're looking for new hires, do you list AI tools as a benefit?
We don't list the benefit, but we are starting to look specifically for folks, for instance, who know how to do prompt engineering.
Yes, absolutely. Yes.
Okay, Jared, what are your thoughts on that topic?
Yeah, I mean, I agree with both of them, not surprising at all, that we are at this tipping point. And I think of it as Ethan Mollick, who's a Wharton professor, will talk about something called the ragged edge of AI, or jagged edge, which just means that AI does really well at some things, surprisingly, and really poorly at other things, surprisingly. And I think we're at this point, but that edge will continue to move out further and further. And so it will become less jagged where it is jagged today. And so I think, I agree. We'll need outcomes to prove that you need to mandate an AI listener, an AI augmenting me. But I think that we will probably end up there. No, I can't prove it, but I do think so.
Yeah. Okay. Well, I want to thank everybody. That's all the time we have for questions today. I want to thank all three of you for sticking with us here and getting through the rough edges to produce an amazing conversation. Including, please know that our next also for my notes here, I want to let you know that our next program on May 6th will cover the winning edge for keeping nurses happy. We kind of get this conversation going as part of National Nurses Week coming up. A live clickable link will appear at the close of this program, taking you to our registration page for that event. And remember to follow along all week as we cover clinical AI implementation on our website, healthleadersmedia.com. And that will include the YouTube of this wonderful conversation, which will be made available on Friday. I want to thank our panelists again. Thank you very much for a great discussion here. And our sponsors, Microsoft, for making today's program possible. Finally, thank you to those of you in the audience for participating. We hope you enjoyed today's program, and we look forward to seeing you during our next program and other Health Leaders programs. Thank you very much.